Hi, good evening. Welcome to our Bowel Cancer Awareness Evening. I'm Brenton Fisher. I'm a GP from Staunton and a representative for TWNS network of GP surgeries in Gloucestershire. And this covers Tewkesbury, Newent, West Cheltenham and Staunton. So thank you very much for joining us. The bowel cancer is one of the most common cancers in the United Kingdom, and we diagnose 40,000 new cases every year. 1 in 20 or 5% of us are likely to develop bowel cancer in our lifetime. And sadly, some famous names who've had bowel cancer include the footballer Bobby Moore, Audrey Hepburn from film, US President Ronald Reagan, as well as Queen Elizabeth, the Queen Mother. Treatment is rapidly improving, and as a result, mortality rates are dropping. And impressively, the deaths have halved since the 1970s. But there are still 17,000 bowel cancer deaths in the UK every year. And it is thought that more than half of these are preventable. If caught early, it's felt that 90% are curable. And so the aim of this evening is to raise awareness and understanding. Treatments are improving. Prevention is best, but the next best is early detection. And that's what we're having a chat about tonight. We are very, very fortunate and grateful for the support and expertise and advice from Mr. Neil Borley this evening. Mr. Borley is an incredibly experienced colorectal surgeon who has led many of the advances in Gloucestershire with regards to cancer care in colorectal surgery, and is the lead cancer clinician in Gloucestershire. This evening we'll be covering what bowel cancer is, what the symptoms are, what the screening program does, who to contact if you are concerned, the role of the GP, and then of course the role of the hospital specialist team with regards to the treatments that are on offer. So please do post questions. We'll be having a look at these. Hopefully a lot of these will be answered throughout the session. But if we have time at the end, we'll try and cover any of those that we felt we haven't been able to address. So Neil, thank you very much for joining us.
No problem at all.
Very, very grateful for giving up your time this evening. So I'll just start with a simple question. What is bowel cancer?
A very good question. So we think most bowel cancers, not quite all, but most bowel cancers have a relationship to polyps. And that's a word we hear a lot about in various bits of the body. But the cells of the lining of the large bowel are always growing and changing, and they're dying and shedding and getting replaced. And when those cells which replace them, if they develop abnormalities in their genes, the way they grow and the way they divide and behave, they can form little extra growths of the lining of the tissue. It heaps up, and that's what we call a polyp. So polyps in the large bowel are not that common, much commoner than bowel cancer. And most of the time, those polyps will just remain like that, those little nubbins of extra growth. But if the cells continue to develop abnormalities in the way they behave, sometimes those lead them to be able to actually begin to grow into other tissues. So not just where they reside themselves, but actually into other tissues. And that's what a cancer is. That's what a cancer can do, in the sense that if it can get into other tissues, that's when there's a risk that the tumor can then spread elsewhere into lymph glands or blood vessels. So that's really important, that there's a relationship for most cancers between these benign polyps. And it's really important, most polyps do not become cancerous. Most will just stay as little benign polyps. But some do, some get bigger, and some turn into cancers. And we think most cancers started life as polyps. There are one or two other conditions where the cells can get damaged in other ways, not just because they're growing. So certain inflammations of the bowel, ulcerative colitis and things like that. But that's a very rare way for cancers to form. We think most of them that come in the way we see them in our practice come from polyps.
Excellent. Thank you very much. So what are the symptoms and signs that patients should look out for that could be potentially bowel cancer?
Absolutely. It's very important. So It slightly depends where. So obviously the large bowel is a long thing. It starts all the way on the right hand side of your tummy, goes all the way around and is down into your back passage. So we talk about the large bowel. We give it two different names. So the back passage we call the rectum, for various reasons. Doesn't matter. It's all part of the same thing. And the rest of the large bowel we call the colon. So rectal cancer, colon cancer, it's actually all part of broadly the same condition. So it depends where in that big large piece of bowel that the tumour is growing, what sort of symptoms it can create. So typically one's lower down. Bleeding is common, and the things we're most concerned about in that bleeding is it darker colour? Is it jelly-like? Is it mixed in with the motion at all? Is it not just on the paper when you wipe? And is it related to how your bowel functions? So that's another big symptom, is the way your bowels are working, have they changed? And we'll come back to that, I think, a little bit later in the discussion about what we mean by a change in your bowel habit. But anything that's changed. So lots of people have different bowel habits. Some people twice, 3 times a day, some people twice a week. Everybody's different. But one of the really important things is if it's a change for you, above and beyond your normal symptoms. So you think, oh, I used to go twice a week, now I'm going every other day, and it catches me, it's a bit urgent, I get caught out by it. That's different, that's a change. And so change in bowel habit is what we mean, and it can be anything, not just diarrhea, not just more common or more frequent motions. It just can be a bit less predictable, catching you out. Tummy pain, everybody gets tummy pain from now and then, don't they? And there are lots of different reasons, but persistent tummy pain, particularly if you're getting bloating or distension of the tummy, feeling uncomfortable. Sometimes anemia, which can make you tired. Anemia can be a cause, particularly for tumours on the right-hand side of the bowel. And if your tummy doesn't feel right, if it feels abnormal, lumpy or painful, that's occasionally.
Okay, thank you very much for that. That's very useful. Thank you. Which brings us on to sort of screening and the national screening program, and sort of what is it, and what happens when we get these things that drop through the letterbox, and why not to ignore them? I think that's the important thing.
The first thing to say is it's a really, really good thing, screening program. Yeah. It's a really important thing, and I'd encourage everybody. It's a little bit weird asking people to take a sample of their poo, isn't it? But it's really, really important. It's a very effective test. So currently, anybody between the age of 54 and 75 will get sent one of these little sample tests in the post. That's going to change in the relatively near future, so it'll start at the age of 50, and you'll get sent them every 2 years. And what we ask people to do is, it's a very simple test. It's just a little thing which comes in the post. This little spiky bit, it just needs to be popped into a bit of poo to take a tiny little sample. Don't have to touch anything. You just pop it back in there, and then it comes in a little prepaid envelope. You pop it in there, make sure you've got your name and address and all the details on there, and you send it off. And you don't need to do anything else. And what that's looking for, it's a very good test because it's looking for blood protein. So the protein which is found inside red blood cells, it's looking for that. And it's a very accurate test. So one of the good things about it is it's probably the best test we've yet got. It's much better than its predecessor, the old tests. And it's very accurate. It'll tell you exactly how much blood protein there is there. And we know that the more that there is there, the greater chance that there might be of a polyp or a tumour. So one of the good things about this test is it's easy to do. It's a little bit bizarre asking someone, as I say, to take a sample of poo, but really quite simple to do. You get sent off, you'll get sent back a letter telling you whether or not you need any further tests, depending on what the level is that they've found and whether or not we think you should have a further test, or just wait another 2 years and you'll get sent another one. Brilliant. So really good test. Please do it, because not only, we'll go back to that talk about the polyps thing, some things, some of the reasons for the blood sample, the poo to have blood in the motion is because there are polyps there. So this test sometimes picks up polyps as well as tumours, and that's really important because that gives us the opportunity to treat them. So you were mentioning about the idea of trying to prevent bowel cancer. So if we can find some of these polyps, remove them and deal with them, we may well be able to prevent a number of those bowel cancers developing. So this test is not just a test for bowel cancer. It may well also pick up polyps that you don't know you have and that we can deal with.
Brilliant. Thank you very much. The question is often posed to me when I'm sometimes suggesting these tests to patients when we arrange them is quite, how do I do that, doctor? Now, I think some suggestions I've made have been pop a little takeaway box if you've got one left in the bottom of the toilet bowl and have a poo into that. But I don't know whether there are any tips that maybe you could offer with regards to that at all.
Just get some toilet paper and just catch the poo on that just temporarily. You don't have to a nice big thick load of toilet paper. Just catch a bit, dip it in, and then just pop it in the toilet. That's it. Wash your hands. It's done. It's a nice, easy thing to do.
Yeah. And quite often we suggest leave it to people's imaginations how they do it. But again, if you just somehow get a bit of poo on the stick, that's what we want.
It mustn't go in the water first. You just catch it in any way you fancy.
Oh, that's a very good point. So try not to take it out of the water in the bottom of the toilet bowl. That's very important. Thank you. Patients ask us a lot about screening for all sorts of illnesses. Is the bowel cancer screening test one of the best? Is it a very good screening test?
It's a very good test. So it's a very good test, one, because it's quite accurate. It tells us exactly which patients we should pick to have a further test. And as I say, it's not just a test for cancer. Can pick up benign polyps, which might well develop into cancer if we left them. We don't know. And we can deal with those. So it's one of the best screening tests the NHS currently has.
Okay, brilliant. Excellent. Thank you. So please don't ignore them. That's the message. Don't ignore them. So when you've done this test and you get your result back, what might you expect to come through the post? What potentially is what might happen when the results come back?
Can we touch on one thing? So we were talking earlier off camera. One very important message is we talked a little bit about symptoms. One of the big messages is the test isn't perfect. Nothing in life is perfect, and the test isn't absolutely perfect. So definitely do the test and respond to it if you get a letter asking you to go for further tests. But if you develop those symptoms in that 2 years between when you're having a regular test, if you get symptoms, then always take those at face value. If there's a change in your bowel habit just because your screening test said it was fine, you didn't need anything doing a year and a half ago, still go to your GP with those symptoms, because it's really important. It's possible something else has happened. As I say, the test isn't absolutely perfect, but don't ignore the symptoms if you've had a test within the last 2 years, which was unremarkable.
Yeah, and I think that's very important. And I think an example of some of the letters you might get is, we didn't detect anything, but you'll be invited again in a couple of years. And it very clearly points out in one of the letters that you get is that your test was negative, but if you have some symptoms, please go and see your doctor. And as Neil mentioned earlier, just to summarize them again, it's a change in your poo, such as softer poo, diarrhea, or constipation that's unusual for you, needing to poo more or less often than usual, blood in your poo that may look red or black, bleeding from your bottom, a feeling like you need to have a poo, so that urgency, that feeling you need to, almost like you get caught out, I think, as Neil mentioned earlier, which was very important, a pain in your tummy, possibly even a lump in your tummy that you might feel and be concerned about, bloating, losing weight, or feeling very tired, as Neil mentioned, which could be a symptom of anemia, which could, of course, be one way in which bowel cancer might actually present. So
you spoke about that. So a common question is IBS, irritable bowel syndrome, is a common thing, isn't it? Lots of people have bowel symptoms. Hemorrhoids are common. They cause a bit of bleeding. And a lot of people say, well, how do I know? What kind of symptoms? How do I know when it's IBS? When should I present those symptoms to my GP? And the answer is, if in doubt, best present it. That's the first thing to say. It's really important. But it's this key, this change. If you say, well, I've had hemorrhoids for years, 20 years, but recently that it's more often the bleeding, and it seems to be larger, and it's sometimes with the motion. So it's those changes. So if you have hemorrhoids and there's a new symptom, we think it's just different, the answer is that's when to present. So that's a really important message as well.
Absolutely.
IBS is common. People get bloating, they get tummy aches. But if that's new, it's different, it's not normal for you, it's not my normal IBS, then that's a time to say, I think I should go to my GP.
Absolutely. which I think would be a perfect time to speak about what will happen when they come and see me. Yep.
Over to you.
So yeah, so when you come and see us at the surgery, we'll have a listen to your symptoms. We'll ask you questions about it. We'll then do an examination. Now, that examination may likely involve us doing examination of your back passage. Please don't be embarrassed about this. This is our job. This is what we do. And we'll make it as comfortable procedure as possible for you. Once we've examined you, we may most likely arrange a few other tests, and that will help us decide whether we can reassure you, or on the basis of some of the results that we have, whether we need to actually refer you on to the hospital, just to decide whether further tests that the hospital can arrange and perform that we can't, to refer you for those. Yeah. So important. Please do come and see us. Don't feel embarrassed. We want to detect the problem cases as early as possible, because as I mentioned in my brief at the beginning, if caught early, most are curable. Beyond seeing the GP, we've decided, well, we need to refer you to the hospital. What then can we speak? So there's two pathways that you might end up at the hospital. It might be you get a letter from the screening program to say we need to arrange some further tests, and then of course it may be that you go to see your GP with some symptoms you're worried about, and then you get referred that way as well. I might just add that actually, if you do come and see your GP and we are concerned about your symptoms, it's likely that we'll refer you along a pathway called the urgent referral pathway. Now, we do a lot of these referrals. The presenting symptoms are usually at a very low threshold for concern. So we are referring considerably more patients. I wouldn't say that we need to. I think we are referring considerable amount of patients because we want to detect all the cases as early as we can. So I don't know whether you have any figures, Neil, about.
I think that's really important.
Yeah.
So we're set up to try and detect things early and pick up symptoms. So that was one of the points I was going to make, Brenton.
Yeah.
The vast majority of people who come to see us because of concerns, and the GPs assess those and then send you on, the majority of people will not have anything of concern, will not have either a cancer or possibly even polyps. So lots of people have tests and it'll all turn out to be a storm in a teacup.
Absolutely.
But it's very important that we still do those.
Absolutely.
There are some questions coming in. I think we said we'd take those. We'll
deal
with them as we can. So definitely looking at those questions.
Thank you very much. We're not ignoring them, but we may well cover them as we move along. So we will cover the ones we haven't sort of at the end. So thank you for that. Please do keep posting them.
So both of those pathways Brenton mentioned, the screening pathway, it's a case of trying to find people we should do further tests. And the reality is we have to look at the large bowel. The best way of trying to find out if there is anything there, if there are any polyps, is to physically look at the large bowel. So that's a colonoscopy procedure, a telescope test, an endoscopy of the large bowel. Those are kind of the terms we use. And most people do not like the idea of that. Let's be honest. I'll be free. I've had a colonoscopy. I wouldn't have them every 5 minutes, but it was no big drama. But it is undoubtedly still the best test. So the best test we would offer is a colonoscopy if it's possible. So let's just talk about a little bit about that. We have to have the bowel empty to have a really detailed look. So it involves drinking some jollop beforehand, which will clear the bowel out completely. And that's a bit of a drag, but it's just drinking stuff which clears the bowel out. The reason the colonoscopy is such a good test is because it allows us to physically look at the lining in detail. So it's a very good test. It will pick up nearly all cancers, large polyps. It'll pick up even small polyps. It will also pick up other things which might have caused symptoms like inflammation, irritation, diverticulitis, other sorts of problems with the large bowel which are not related to cancer. Common question people have is, can I have a scan instead of a colonoscopy? Because people don't like the idea of a colonoscopy. We understand that. And the honest answer to that question is yes, but no. in the sense that we have two other tests which we can do for patients. A plain scan of the tummy, which is what a lot of people would like to have, a CT scan of the tummy. Unfortunately, it's not a very good test. If there are really obvious problems with the large bowel, it will pick them up, but it will not pick up small polyps. It will not pick up some small cancers. It will miss lots of things. So a plain scan of the tummy is not a good test. There is a colon scan, which is possible. That still involves drinking all the dollops. We've got to have the colon open and empty. It still involves having something up the bottom because we've got to blow air inside the colon to enable us to get it distended, so that when we do a scan, you then have a scan, in fact two, one on your front, one on your back. When those scans are examined, the computer, it's basically artificial intelligence, which has a look at those and says, and then gives it to one of our consultant colleagues who has a double look at that. Is there anything odd apparent in terms of the shape of the bowel? So that's a good test. It will pick up most cancers and most polyps. It can miss little polyps, and it's not very good at picking up inflammation. So it's not quite as good as a colonoscopy. So those are the tests we would use. Colonoscopy remains, unfortunately, the best test. So that's what we would expect to do.
How long does a colonoscopy take? How long could a patient expect to be lying? Are they lying on their? They're lying on their side.
Yeah,
I think that's the procedure, aren't they?
most of the time. Sometimes we turn people over. We have to, because it helps the bowel folds a little bit, and to straighten it out to make it easy to pass the telescope. Sometimes we ask people to turn over and so forth. So that's one of the things we need people to be able to do. The whole process is about a half a day. So you come up to an endoscopy unit. We try and get people through, obviously, in a process as quickly as we can, but the whole thing's about a half a day. The actual process itself, going in the room, the process in the room is about 45 minutes. The actual telescope bit, probably 20-25 minutes, depends. If there are polyps to remove, obviously it'll take longer. But that's one of the key things. One of the great things about colonoscopy is we can take samples, we can take biopsies, we can remove polyps, whereas of course we can't do any of that on any of the scans. So it's another reason why colonoscopy is such a good test.
Excellent. And I think a question I've often had before is will it actually hurt if you're actually doing things like removing polyps or taking samples or things like that?
No. So removing polyps doesn't hurt because the colon has none of those sorts of nerve endings. If we're really honest, it feels rather bloating. You get a distension of the colon as the telescope goes round. As I say, I can speak from experience. And the answer is, it wasn't a drama, but it's, you feel the telescope going round. Some people have a little bit of sedation to have it. Some people don't have any sedation at all. We don't need anything necessarily. As I say, I had mine without anything. But lots of people have a bit of sedation. Most people find it perfectly acceptable, perfectly tolerable.
Excellent. Well, hopefully that reassures a lot of individuals about the anxiety about going to have these tests and things like that. So then, and please do continue asking your questions if there's something we haven't covered about the procedure itself. But I think hopefully that's sort of covered majority of that. So should we talk a little bit about sort of results or things like that, or that, I mean, again, at the end of the day.
So one of the good things about colonoscopy is if you're invited for a colonoscopy. So if you have a positive test, that is the screening test, you get that sent off and you get a letter saying, we think you should have a colonoscopy to check your bowel out. Again, I would stress the majority of people will not have a cancer. They might have polyps, but actually the majority of people won't have a cancer. But one of the great things about colonoscopy is basically we know the answer immediately. Because you've had a look at the bowel, and most of the time we can say, particularly if it all looks normal, we say, I haven't found anything, and you know the answer then and there. So you walk away from the building knowing what the answer is, that there's nothing there. Obviously, if there are polyps removed, we say we have to send them to the labs. They'll get fully assessed, and we will not know exactly what's going on. But most of the time, whether or not there's anything there and what we think it might be is known immediately. So most results are kind of known immediately because you've done it.
Yeah, brilliant. And like I say, I think, unfortunately, as we mentioned at the beginning, the majority of patients do walk away with some reassurance at the end. So if someone does have something of concern that comes up from the result, what's the process with regards to that discussion, that conversation you might have with someone in clinic afterwards?
So obviously it varies definitely according to the person. their age and exactly what we found, where we found it. But in broad principles, we'll then do some further tests. If we think we found a cancer, we'll take some samples from that to confirm it, and then scans to assess the cancer and decide how best to treat it, how best to tackle it. Broadly, and surgery does feature. Surgery is the commonest treatment for an established bowel cancer. Now, we would very much hope, and indeed it's true to say, that the screening program has made it that there are many more earlier cancers being detected. And the earlier we can detect them, the smaller they are, the more likely they are not to need radical surgery. Sometimes we don't need to do surgery at all. We can do microsurgery or polyp removal if they're really early. So that's a really important thing about the screening program. But it depends exactly how the cancer is. We need to have a look at it with scans and then plan treatment. I think it might be worth saying, so a common question nearly always, whatever the diagnosis, when we have a bowel cancer diagnosed, in the back of most people's minds is the question, will I need a bag? Okay, and it's nearly always in people's minds. And I stress to say, the vast majority of bowel cancers, even when they're treated with surgery, do not require a bag, a colostomy or an ileostomy bag. And actually, only a small minority ever end up with a permanent bag. So most bowel cancer can be treated without that. I know it's a worry for an awful lot of people, and it might worry them about coming forward because they might think, oh, I don't want that as my treatment.
Absolutely.
It is unlikely.
Well, that is very reassuring, and I think certainly it's not something that I see in my practice. Patients coming out of hospital and needing bags and things like that, which is incredibly reassuring. I just thought of something. With recent changes in trying to get diagnosed quickly, I've warned my patients these days that actually from the time of seeing me, I'll then make a referral. They might then get a phone call. Yes. And they might not actually meet a human being until they actually go for the colonoscopy. Yeah, absolutely. Or for whatever investigation they might be having.
Yes. So if we go back to people who come to see you with symptoms. Yeah, absolutely. So we've tried to speed things up. Going off to see me or one of our team in clinic to discuss things is just one other step in the pathway. So if Brenton and the team have assessed people and say you're fit enough, you're good to go, you could have a colonoscopy, then we would like to discuss that. So you're right. So a telephone assessment, talk you through it, what it involves, what it's going to be like, all that kind of thing. Check your physical health, all those sort of medications, things like that, and then hopefully be able to book you straight in for that colonoscopy to speed things up. Yeah.
So please don't think it's an impersonal approach. I think this is actually a way in which we can help to alleviate your concerns as quickly as possible, is by getting you, let your only trip to the hospital be for the test that you're going to have. So it saves unnecessary journeys, unnecessary anxiety, and basically hopefully a very, very early outcome and reassurance. Okay, brilliant. Thank you. So we've discussed surgery as the treatment options, but are there other sort of treatments that some patients might need?
Yes, yes. The answer is yes. It's possible. So the vast majority of bowel cancers, if it's possible to physically remove them, that is our best treatment. So that's surgery. Occasionally, there are a very small number, mostly tumours of the back passage, the rectum, which we talked about earlier, where we give some radiotherapy to help shrink the tumour down before we operate on it. And of course, after an operation, we assess the tumour in great detail. So the specimen, all the tissue related to that is sent off, a very, very detailed assessment by the laboratory team, the histopathology team, and they'll tell us what the behaviour of the cancer looks like. And then depending on how the cancer looks like it's behaving, sometimes we offer, it's not obligatory obviously, we offer patients an additional course of chemotherapy. But the majority of treatment for bowel cancer remains an operation.
Yes.
Now sometimes, as I said, those operations can be, for really early cancers, they can be endoscopy procedures. We might even, the really super early ones, like a little polyp cancer, we might be able to remove it without any major surgery. Microsurgery for tumours of the back passage, which are small and early, so again, not major surgery. So it's not just big surgery.
Yeah. Excellent. Well, that's very reassuring. So what might the future hold, Neil, for I think, well, again, diagnostics, I don't know about diagnostics, but certainly the future hold, I suppose for diagnostics maybe, but also basically for treatment in the future, or maybe prevention. People ask us all sorts of questions about.
So there are a couple of things about that. One of the things you spoke to me earlier about was about cancer vaccines, which is a term which is bandied around a little bit. When it comes to bowel cancer, it's important to understand. Most people think a vaccine is something you have or you give to your children to prevent a disease like measles or rubella. Cancer vaccines aren't that. So we're not talking about something that you just give to everybody, normal people, stop them getting cancer. Cancer vaccines for bowel cancer, it's about people who have bowel cancer and trying to use the tissue we have and the information we have about their cancer to prime their body against their own cancer, to make it work better that way. So that's on the horizon. For people who have cancer, we're getting more and more what we call targeted therapy. So we understand more about the abnormalities, the genetic problems different cancers have, and that it makes them suitable for certain sorts of treatment, certain chemotherapy, and also what we call immunotherapy. So using antibody treatments to switch off or turn off the cancer cells, so that makes them more susceptible to the immune system. So different treatments. That's we're going to know much more about that in the next decade or so, more and more about that, and it'll be more and more tailored treatment.
Excellent. Yeah.
And we'll probably understand more about the development of polyps. So a couple of the questions we're looking at is about that, the kind of development of cancers and polyps. We know that genetic abnormalities in the polyps are the key thing, and how they develop. And we used to think that about 1 in 20, 5% of all cancers had some kind of genetic link in the family. We now know that it's much more than that, probably at least 20, 25% of cancers. And again, we know more than we did 20 years ago in terms of the precise genetics. We analyze cancers now for lots of different aspects. We deliberately analyze their genes when we have them. But we'll know more and more about that. So the next 10, 20 years, we'll understand a lot more. There may be preventive strategies for that in terms of advising people. But one of the questions was about that thing, family history. So if I can, maybe now would be a good time to touch on that.
Yeah, so one of the questions, was both my parents have had bowel cancer. Thank you very much for who posted that. And am I at increased risk? How often should I get checked? Yeah.
So, and that's a very good question. So the answer is, as you said, unfortunately, bowel cancer is common. So actually, even with modern families that aren't quite as big as they used to be, it's not uncommon to have one, maybe even two relatives who've had bowel cancer, and that's just random chance, because 1 in 4, 1 in 5 of us may develop it.
Yes.
But yes, the more relatives and the closer they are to you, so parents, and particularly if those are related, so your parent and their sibling or their cousin and their grandma, that might be something which indicates potentially an issue, and that's something that's worth discussing. So there's a whole setup for us in terms of assessing that risk, the genetic risk of a bowel cancer, but it's definitely something to discuss with the GP if there are lots of members of the family, particularly if they're closely related. And sometimes we'll test those families, and for people that we consider to be at higher risk, they'll go on their own special kind of screening program where they get checked specifically. But we obviously have to pick the people that we think are at the greatest risk. So that is very important.
Exactly.
Family history, yes.
Thank you. And I'm not going to go sort of off-piece talking about genetic history and sort of what happens when you come and see your GP about that, but it's some very clear pathways that we follow with regards to who we need to refer and who we might not need to refer. So again, if you have concerns, obviously do discuss that. I think that, which is very important. So let's have another question here. This is interesting. I don't know if we can answer this. It says, how long does it take for a cancer to develop? And I suppose that very much depends on how aggressive it wants to be.
Well, it's a very good question. And the answer is much longer than you think. So different cancers in the body do grow at different rates. And kind of fortunately or unfortunately, depending where you look at it, bowel cancer is a relatively slow growing and slow developing problem. So we used to think all polyps and cancers kind of had the same growth pattern. It's not true. Some do grow faster than others, and polyps go from cancer to go from a benign polyp to a cancer more quickly than others. But it usually takes quite a long time. So that growth between a polyp can be 1, 2, even 3 years as that growth and change.
Exactly, which probably is sort of answers our next question here, which is, if I have polyps, what are the chances of them coming back? And I suppose that comes into sort of the follow-up that you might have if we find something on a colonoscopy, and then to say, right, we're going to have a look at this again in
very good question.
2 years'
Excellent
time.
Question.
Yeah.
And the answer is it depends. It depends how many polyps you have, how big they are, and precisely what sort of polyps. So I said that the cells become a little bit abnormal and grow in an abnormal way, and there can be differences in that. So each polyp is assessed and analysed for its own behaviour, and there are very clear national guidelines who said if you have so many polyps and over this, then you need a check-in 1 year or a check-in 3 years, or if it's just a couple of tiny little polyps, you don't need a check at all.
Exactly.
So yes, if you have polyps found at your colonoscopy and they're removed, we'll definitely have a plan as to whether or not you do or don't need, and that plan is adjusted depending on what we think the risk is, how often checks might need to be made.
So very bespoke to the individual. So if your neighbour has a similar situation to you, don't compare each other. I think that's the important thing.
It's the number and the size, and to a degree whether or not there's any family history.
Okay, brilliant, fantastic. I don't know whether we can answer this, Neil. I don't want to be unfair to ask you this question if it was, but why is the cutoff point 75?
You could equally ask the question, why is it not 45?
Exactly,
The honest answer is resources. That colonoscopy is an excellent test. It's a very, very good test. And one of the reasons we love it so much is because in reality, it is as much to diagnose cancer as to try and prevent it. Because if we can find polyps and remove them, we will potentially prevent cancers. And we know that. You were mentioning Ronald Reagan, and there's something in America called the Reagan effect. So when Ronnie was diagnosed with his cancer, the white middle-class Americans all ran off and had their colonoscopies. And about 5, 10 years later, they noticed a fall in the rate of cancer in that group. So we know that if you remove polyps, it is possible to prevent it. So it's a really good test. The problem is, colonoscopy is expensive and difficult to do. It takes lots of skilled people and lots of environments. So in reality, the NHS doesn't have the capacity to do as much as we'd like to. We also know that as you get older, if you haven't developed polyps by the time you're 75, you're less likely to be somebody who will develop them. So some people will never, ever, whatever happens to them, will never develop polyps. Some people are more prone. So effectively, that's why the cutoff is at that age. So there's no point keep looking if you haven't found anything by that age.
And I must stress that that's the cutoff for screening. I think if you are 75 plus and you have concerns about your bowel patterns, a change in a list. I'm happy to read through that list again, just to reiterate that: a change in your poo, such as softer poo, diarrhea, needing to poo more often, or getting caught out before you go into the loo, blood in your poo, which may be red or black, bleeding from your bottom, a tummy pain, a lump, bloating, weight loss, very important as well. Again, and you are concerned, then please go and see your GP. That's very important, and that's for all age groups. I think that's very important. It's to say that it's the screening program where the cutoff is at 75. But again, at the end of the day, if you have symptoms, please do present yourself to the doctor. That's very important. Okay, thank you. Right, I think, I don't know if there's anything else. I think we've pretty much covered through my list of questions, Neil, and I think we've gone through the questions that are on the chat there. So I'll give it a few more minutes just to see if anybody else wants to post anything. But were there any other sort of parting shots or things that you feel that you wanted to add at all that we may or may not have covered yet?
No, I think one of the key things you mentioned about age is one of the big drives in surgery has been safer surgery. And so you're talking about advances. We're aware that until we can catch things earlier and earlier, and major surgery becomes less and less important part of my practice, my life, my working life. One of the best things we can do is make that safer, particularly for older patients. And that has been a big drive. And that's one of the big messages that as we've got better at that, you said about the mortality. So risks of surgery have come down with time. We're better able to do surgery. Robotic surgery, you're talking about advances. So more keyhole surgery. The next big advance is robotic surgery. So keyhole with robot assistance. And that all improves how we can do the operation, potentially makes it a bit safer. And therefore we can offer that operation, that surgery to more patients. So, and it is important as we get older, as you say, our population is getting older. So it is important.
Exactly. I think the recovery times for these newer surgeries are better. So shorter hospital stays, less chance of developing complications afterwards as well, which is again the whole reason about trying to advance and improve outcomes from the situation in that regard. So I think that is the last few questions that were posted. I think there were
there's a question about diet and cancer and
polyps. Oh, sorry, I'm so sorry, I missed that one.
It's a difficult question. The reality is we know from some studies that generally for an entire population, if we talk about the country as a whole, if we ate less red meat and had a higher diet in fiber and fruit and vegetables, that sort of 5 a day, if we did more of that, we would probably see a reduction in the amount of bowel cancer we have. On an individual basis, it's excellent for our general health. The amount it actually impacts the risk is modest, should we say. So the honest answer is, from a personal point of view, yes, it's a really good thing in terms of diet and lifestyle, but it's not a guarantee against that.
No.
Unfortunately, lifelong vegan vegetarians can develop bowel cancer, and it's just part of that. So yes, it's very important, but it's not really the most important thing. The most important thing is checking those symptoms, trying to spot the changes, definitely doing the screening program when it becomes available, particularly as the age range comes down.
Absolutely.
So those are the most important things you can do.
Yeah, absolutely. Thank you. That's very important. Thank you very much. I think that pretty much covers our topic this evening. Thanks to all that have joined us this evening, and I hope it's been informative. I hope that it's made you want to get your toilet paper and little curry dishes and whatever else out to try and do your screening program. If it's been sat on the mantelpiece or somewhere for a while, and maybe go and dig it out and sort of find it and do it if you are concerned about it. If you have lost it, if you had thought, you know what, I didn't want to do it, and tonight's inspired you, and you feel, you know what, I'm going to do something, but you just can't find that anymore. You think it's probably ended up in the recycling bin. You can contact the bowel screening program. The number is 0800 707 6060, or just put bowel screening NHS UK into a search engine. The information will be there on the NHS website. So please, if you've missed it, or you haven't received a notification you think you should have, give them a call. This is a situation where, don't take this comment the wrong way, probably don't ring your GP about that. We won't be able to answer that, unfortunately, but the bowel cancer screening program will be able to field those answers for you with regards to that, or send you a pack, to get yourself tested. I want to. Do you want to
you asked me. So my key messages would be, yes, definitely screening program. Please do it. It literally could save your life.
Yep.
2, everybody just being focused on what their bowel symptoms are and noticing those changes. Change is everything. Report it, think about it, and if necessary, consult your GP with it.
Absolutely.
And the advances in surgery and our technology are definitely making bowel cancer treatment safer and better, more effective.
Absolutely. Brilliant. Well, thank you very much. And I think thank you so much to Mr. Borley for giving up
my pleasure.
Your time. He's a very busy man. but he was very excited about joining us tonight. And I hope you all enjoyed the learning new things. I certainly learned quite a bit about, I'm embarrassed to say, I've learned a bit more about what a polyp is and how cancer develops. So, but again, I think the important thing is it was getting the message across. So thank you very much for joining us. We will links if you want to tell your friends about this evening. I think we will be posting links to these on our practice Facebook pages in future. So if you if anybody would like to have a look back at it again, we'll do that. But I think we'll wrap it up and say thank you very much, and
My pleasure.
have a lovely evening, everybody. Good night.
Good night.
Good night.